So today my topic of discussion is treatment of tuberculosis. Okay. So আমি আগের ক্লাসগুলোতে তোদের বলেছিলাম what is tuberculosis and how do you diagnose tuberculosis, be it pulmonary or extrapulmonary. So what is the basis of treatment of tuberculosis? First, you have to know what is the diagnostic algorithm of tuberculosis. If a patient attends your OPD with a history of, this is a diagnostic algorithm, with a history of fever and cough for more than 2 weeks plus minus hemoptysis, then this is the case of presumptive pulmonary tuberculosis. You can label it as a case of presumptive PTB. Then you have to do sputum smear examination and radiological examination, that is chest X-ray PA view accordingly. Okay. So there may be 3 possibilities. The sputum smear examination may be positive and X-ray may be suggestive of tuberculosis. Smear examination negative, X-ray suggestive, and both are negative. Okay. So what are the possibilities of X-ray where you can find it as a active pulmonary tuberculosis? What are the signs of X-ray you look for? So first thing is cavity, presence of cavity, most importantly in right upper lobe and left upper lobe as well. Second, satellite lesion. What is that? So suppose a cavity or a consolidation in right lung and there is another consolidation in left lung, the opposite lung. So that is the satellite lesion of the first lesion. This is called satellite lesion. Presence of bronchopneumonia or presence of miliary tuberculosis. So these are the X-ray features of tuberculosis. And if the sputum smear is positive and X-ray be it positive or negative, you will label it as microbiologically confirmed pulmonary tuberculosis. So in all those cases, you have to do CBNET examination. This is the new guideline. This is the old chart, old guideline chart. So in all microbiologically confirmed tuberculosis cases, you have to do a CBNET examination to look for whether there is presence of rifampicin resistance or not, because there is emergence of rifampicin resistance as well as MDR-TB in India in recent 10 to 15 years. So you have to do CBNET examination. So if smear examination is positive, X-ray suggestive or not suggestive of TB, you have to do a CBNET. And if Mycobacterium tuberculosis is detected, so CBNET report consists of 2 different columns. First, Mycobacterium tuberculosis detected or not. Second, rifampicin resistance detected or not. So Mycobacterium tuberculosis detected, rifampicin resistance not detected. That means this is a case of drug sensitive TB. So treat it accordingly. And MTB detected, rifampicin resistance is intermediate or indeterminate. That means we have to repeat the sample. Second sample, first sample, second sample. And third thing is, if smear is positive for Mycobacterium tuberculosis and rifampicin resistance also detected, that means this is a case of DR-TB, be it rifampicin resistance or MDR-TB. Okay. And if neither sputum smear examination or CBNET results in positive finding of Mycobacterium tuberculosis, but X-ray is suggestive of TB, or you have very high clinical suspicion that this case must be a TB, be it sputum smear negative or not. So you may have proceed with the diagnosis of DSTB, clinically diagnosed DSTB, sputum smear negative but X-ray suggestive of tuberculosis. That means this is called as clinically diagnosed tuberculosis, drug sensitive or drug resistant. So next, what is presumptive TB? So just I have told you what is presumptive TB. If a patient have complaint of 3 symptoms, that is fever for more than 2 weeks, cough for more than 2 weeks, or hemoptysis. So these people are called as presumptive tuberculosis affected patient, presumptive TB. Next, So what is microbiologically confirmed tuberculosis? If the specimen, that is sputum smear or bacterial culture or gene expert, results in positive Mycobacterium tuberculosis, then it is called microbiologically confirmed pulmonary tuberculosis. Then what is clinically diagnosed pulmonary tuberculosis? If it is negative for sputum smear or other examination or culture, but X-ray is suggestive of TB or the histopathological finding suggestive of tuberculosis. So what is the most important and most specific histopathological finding of TB? Presence of caseating granuloma, right? So actually there are four classifications, rather I would say that the structure is divided into 4 parts. First, in center, this is caseous necrosis. Okay. First, center, caseous necrosis, followed by epithelial cell, sheet-like cell, that is epithelial cell. Next, Langerhans giant cell, and the last part is lymphocyte, area of lymphocyte. So this is a tuberculous granuloma. Okay. So this is called clinically diagnosed tuberculosis. And in children, so what is the children cannot expect to a sputum, right? So what is the method of microbiological identification of in case of children of tuberculosis? Gastric lavage. So actually the yield of gastric lavage is very less. So if a child attended your OPD with a history of presumptive tuberculosis, or he has a history of contact with a sputum positive tuberculosis patient, and you have very clinical suspicion, high clinical suspicion of that the patient must have tuberculosis, then you would go for starting ATD, okay, regardless of microbiological identification. Next, case definition. So according to the NTP guideline, there are 5 types of cases. First is new case. So what is new case? That is newly diagnosed as pulmonary tuberculosis, that is newly diagnosed as tuberculosis, and or previously he was diagnosed as tuberculosis, but he has not consumed ATD for more than 1 month. This is called new case. Second, what is previously treated patient? If the patient was treated previously for more than 1 month with ATD, this is called previously treated tuberculosis. Next, what is recurrent TB case? Suppose the patient was diagnosed with TB in previous years or previous months, and he was successfully treated and was declared cured at the end of his therapy. So at the end of 6 months, the sputum smear was negative. So he was declared as cured, but in subsequent days he is having again presumptive TB symptoms and sputum smear is again positive. So this is called recurrent TB case. Next, treatment after failure. So that means the patient had history of tuberculosis and he had also taken ATD for 6 months, but he was still sputum smear positive. He was not negative at the end of treatment. This is failure. Next, so what is treatment after loss to follow-up? So in recent course of tuberculosis treatment, the patient was taken ATD for 1 month, more than 1 month, and he was lost. He has not followed up in subsequent visit. Subsequently, after 5 or 6 months, when he attended your OPD, you found that the patient is still sputum smear positive. So this is called treatment after loss to follow-up. So this is according to the history of previous TB treatment or ATD treatment, and the other case definition according to the resistance of the drug. First is monoresistant. So what is monoresistant? What is monoresistant? Any one of the first line drug, resistant to any one of the first line drug. So that is monoresistant. So what is polydrug resistant or PDR? Any 2 of the first line except H or R, isoniazid or rifampicin. This is PDR or polydrug resistance. So what is MDR? Drug resistant Rifampicin and Isoniazid. So the monoresistant can be isolated Isoniazid resistant, can be RR, can be Pyrazinamide resistant or Ethambutol resistance. But MDR-TB must be RR plus HR, Rifampicin plus Isoniazid resistant, plus minus other first line drugs. So what is XDR? Extensive drug resistance. So MDR, that is RR plus HR plus second line, that is Fluoroquinolone plus injectable aminoglycosides. Okay, so this is called XDR. So what is pre-XDR? This is the new term. What is pre-XDR? RR, that means MDR plus Fluoroquinolone, not aminoglycoside. So this is called pre-XDR, pre-form of XDR. Actually, তোরা দেখেছিস এখানে বেসিক্যালি ওভার দ্য কাউন্টার ফ্লোরোকুইনোলোনের অনেক ইউজ আছে, তাই তো? কোনো পেশেন্টের হয়তো একটা ইউটিআই আছে, দ্যাট ইজ মোস্টলি অ্যাসিমটোমেটিক, দ্যাট ডাজন্ট রিকোয়ার এনি ট্রিটমেন্ট, বাট কোনো হয়তো মেডিসিন শপ তাকে একটা লিভোফ্লক্সাসিন দিয়ে দিয়েছে, রাইট? সো দিস লিডস টু fluoroquinolone resistance. So the two respiratory fluoroquinolone that has anti-tubercular property are levo and moxi. So you must be judicial enough to give these two fluoroquinolones rampantly, because there is increased chance of pre-XDR, especially in last 5 to 10 years in India. So capreomycin was there in previous regimen, but it was now has been omitted from the therapy. So this is familiar to you, right? The drug sensitive TB. So what is the regimen? What is the regimen? 2 HRJD plus 4 HRE. That means 2 months is HRJD, Isoniazid, Rifampicin, Pyrazinamide and Ethambutol, followed by 4 months of HRE, Isoniazid, Rifampicin and Ethambutol. So why Pyrazinamide has not been added in the next 4 months? No. This is IP and this is CP, right? The 2 months is IP intensive and the 4 months is CP. So why Pyrazinamide has been omitted from the CP? Because in first 2 months the TB bacilli are much more active. Okay, so TB bacilli actually proliferates in acidic environment. So they create acidic environment inside the cell because of their metabolism, active metabolism. Pyrazinamide needs that acidic environment to activate itself to form pyrazinic acid. That's why after 2 months the organism is not metabolically very much active. So pyrazinamide may not be active at that phase. That's why Z is exclusive for the IP phase, not the CP phase. And moreover, so what is the basis of or backbone of NTP drug treatment? What is the backbone? তোরা সবাই পড়েছিস কমিউনিটি মেডিসিনে, that is DOTS. So what is DOTS? What is the full form of DOTS? Directly observed treatment short course, right? Directly observed treatment short course. So directly observed, that means the treatment provider has to observe the patient that he or she consumes the drug in front of the provider. That is the directly observed therapy. Okay, and short course, why short course? Because 20 to 30 years back the therapy was for 9 to 12 months. So it is short course, it is now 6 months. This is short course, directly observed treatment short course. So this direct observation leads to less treatment failure and less adherence chance. যদি কোনো পেশেন্টকে তুই সামনে থেকে বলিস যে তুমি প্রতিদিন এসে, বেসিক্যালি যেটা করে আশা প্রোভাইডার্স, আশা কর্মী যারা আছেন তারা হচ্ছে প্রত্যেক পেশেন্টের বাড়িতে যায়, তাদের বলে ইনস্ট্রাক্ট করে যে পেশেন্ট তার সামনে যেন পিলটা ইনটেক করে, দ্যাট ইজ ডাইরেক্টলি অবজার্ভ। ওকে, so this is dots and directly observed. So the IP phase is for 2 months, that is 8 weeks, 56 doses, and CP phase is how much months? 4 months, that is 112 pills, 112 doses has to be taken, right? So IP phase cannot be extended beyond 2 months, but CP phase can be extended in special circumstances like tubercular meningitis, in case of other CNS TB, or bone TB like spinal tuberculosis and disseminated tuberculosis. The CP phase can be extended. So what is this? Do you know? এটার সঙ্গে কোনো দেখেছিস এটা এইরকম প্যাক, টিবির প্যাক তোরা দেখিস নি কোনোদিন? So this is a anti-tubercular drug pack. So that এখানে this is the first dose, this is the second dose. Okay, so after having second dose এখানে একটা ফোনের একটা সাইন আছে। So after completing the second dose, suppose a patient actually আমরা কি দিই, আমরা হচ্ছে FDC দিই, তাই তো? FDC means fixed dose combination. So 4 FDC and 3 FDC in CP, in IP and in CP. So this FDC is adjusted according to the weight. Suppose একটা পেশেন্টের ওয়েট কম, তাকে 2 FDC দেওয়া হয়। একটা পেশেন্টের ওয়েট, আমি ওয়েট বেস চার্ট আমি শো করব কি কি আছে, তাকে 3 FDC দেওয়া হয়। সাপোজ এই পেশেন্ট ওয়েট কম, তাকে 2 FDC আমি প্রেসক্রাইব করেছি। সো আফটার হ্যাভিং, মানে 2 FDC মিন্স দ্য পেশেন্ট must have to consume 2 pill a day, 2 FDC pill a day. So after completing the second pill, first pill and second pill, the patient have to call to a phone number. That is, এই যে এই প্যাকটা যদি ওপেন করে, এই যে সেকেন্ড প্যাকটা, এখানে একটা ফোন নাম্বার আছে। The patient has to give a missed call to that number. That means the patient has consumed the therapy properly. This is the new regime. This is called 99 dots. 99 dots. Okay. This is the new initiative of Government of India, and this leads to less treatment failure. Okay. So this is the weight-based regimen. Weight-based regimen. So এরকম ভাবে মনে রাখবি, HRZD, right? 5, 10, 25, 15. 5 mg per kg আর H, তারপর 10 mg per kg আর 25 mg per kg Pyrazinamide, and E হচ্ছে 15 mg per kg. Okay, so 5, 10, 25 and 15. This is the weight based regimen. So streptomycin was there in previous regimen, but nowadays it is obsoleted because actually streptomycin has bactericidal and bacteriostatic effect. But যেটা দেখা গেছে ট্রায়ালসে, যে আফটার গিভিং HRZD there is no need of streptomycin other than specific cases like tubercular meningitis, where the penetration of streptomycin is much more in meningeal tissue. ওইখানে কিন্তু streptomycin ইউজ করা যায়, but because streptomycin injectable and daily injection is very painful, that has led to less treatment adherence. That's why streptomycin has been omitted. So first of all, you have to evaluate the patient clinically. First, you have to record the weight and calculate the BMI. Second, nutritional status. Third, addiction history. If the patient have tobacco or alcohol addiction, then he must have to quit the addiction before treatment starts, because it can lead to treatment failure. Third, you have to assess if there is any comorbidity like diabetes mellitus, specifically diabetes mellitus and HIV, because diabetes and HIV may lead to treatment drug resistant tuberculosis and treatment failure as well. And this is the daily dose schedule as per weight band. So this is the FDC. So what are the doses of FDC? 75, 150, 400 and 275 HRZD. এটা কিন্তু খুব ইম্পর্টেন্ট, তোদের এই ওয়েট চার্টও ইম্পর্টেন্ট, এটাও ইম্পর্টেন্ট, তোদের এক্সামে ইম্পর্টেন্ট, প্র্যাকটিসে ইম্পর্টেন্ট, এমসিকিউতে ইম্পর্টেন্ট, রাইট? সো 25 to 34 kg needs 2 FDC and followed by 35 to 49 3 FDC, 50 to 64 4 and 60 to 75 5, more than 75 is 6 FDC. And this is the pediatric drug dose regimen. এটা খুব ডিফিকাল্ট, মনে রাখতে হবে না, জাস্ট অ্যাডাল্টটা মনে রাখবি তাহলেই হবে। So what are the first line anti-TB drugs? HRZD. What are the second line anti-TB drugs? This can be classified according to this regimen A, B and C. So the part A contains the highly efficacious group that must be included in MDR regimen. This is the MDR drug therapy. Must be included in MDR regimen, the group A drugs, all the group A drugs. So what are the group A drugs? There is respiratory fluoroquinolone, there is levofloxacin, mostly levo or moxi. Second is linezolid and third is bedaquiline. So these three are the essential drugs. Second or group B drugs are clofazimine and cycloserine, and group C drugs are rest of the MDR drugs, like there may be para-aminosalicylic acid, ethionamide, imipenem cilastatin or petomanide. So like these drugs. So if you prescribe an MDR regimen, the group A, all the three group A drugs must be included. Second, group B, any one of the group B must be included, and group C may be needed to complete the regimen. So there should be at least 5 drug regimen. So to complete that, any one of the group C may be needed or not. That is not necessary. So isoniazid, then some brainstorming with your previous pharmacology class. So slide দেখবি না, আমি slide off করছি। বল, what is the mechanism of action of isoniazid? This is from a pharmacology class. So what is the mechanism of action? Anyone? ভুল হলে বল, কোনো অসুবিধা নেই, বল, কিছু তো ট্রাই তো কর। কি ইনহিবিট করে? আইসোনিয়াজাইড কি ইনহিবিট করে? Yes, mycolic acid, very good. How it does? So isoniazid is an inactive form, right? So it is converted into isonicotinic acid, that is the active form, by the help of catalase peroxidase. That is actually the gene responsible to that is CATG gene. So catalase peroxidase forms isonicotinic acid from isoniazid, followed by this isonicotinic acid actually forms reactive oxygen species and NADH molecule. So these all things inhibits mycolic acid synthesis. So this is the mechanism of isoniazid, right? So this is mostly absorbed rapidly from GI tract and metabolism primarily in liver by acetylation. This is very important. So acetylation, after acetylation, INH converts into hepatotoxic molecules, right? So there are two types of acetylators. One is fast acetylator and one is slow acetylator. So fast acetylator means those patients who acetylates faster than the others and which results into generation of more hepatotoxic molecule from INH, right? So that means the fast acetylator has a more risk of hepatotoxicity, okay, and slow acetylators have more risk of peripheral neuropathy. This is your MCQ. এই MCQ এসেছিল তোদের প্রিভিয়াস INICET 2023 একটা কোশ্চেন এসেছিল। those slow acetylators কিন্তু কি করে, peripheral neuropathy করে, and fast acetylators করে হচ্ছে hepatotoxicity, right? So the metabolism primarily by CYP2E1 and most of the unchanged drugs and its metabolite. So these metabolites which are excreted through urine or kidney, they are non-toxic. So they are non-toxic to kidney also. That's why in case of chronic kidney disease, the dose of INH must not be altered, right? So INH and rifampicin you have to give this in the same dose in case of chronic kidney disease. So what are the most common adverse drug reactions? First is hepatotoxicity, second is peripheral neuropathy and other CNS symptoms. What are the CNS symptoms? Why peripheral neuropathy occurs in INH? Pharmacology. কিসের জন্য? মানে বেসিক্যালি আমি কি দিলে পেরিফেরাল নিউরোপ্যাথি আটকাতে পারি? ভিটামিন বল B6, very good. Pyridoxine. You have to add pyridoxine to that INH therapy. So peripheral neuropathy, even convulsion and coma can occur in INH toxicity. Second, hepatotoxicity, rash and that's all. So the metabolites interfere production of B6. This is the primary mechanism of peripheral neuropathy. So INH can be administered to patients with stable liver disease. Okay, suppose a patient has stable liver disease, he has CLD, but the enzyme or the hepatic function has not altered in recent few years or few months. So you can safely administer INH, but you have to monitor the patient with serial LFTs, right? Then what is the mechanism of action of rifampicin? What is the mechanism of action? Bol, ঠিকই বলছিস? হ্যাঁ, there is inhibition of DNA dependent RNA polymerase, RNAP inhibition, right? So this is the primary mechanism of rifampicin. So what is the pharmacokinetics? Actually rapidly absorbed from GI tract and the absorption of drug is hampered by 30% by food administration. So that's why the absorption of the ATD drugs, specifically isoniazid and rifampicin, is hampered if you take the drug with food. So you have to take the drug before food, right? 1 hour, specifically 1 to 1.5 hours prior to food intake. So distribution, rifampicin is widely distribution through all the tissues, specifically in CSF and meninges. And so একটা পেশেন্ট রিফাম্পিসিন খাচ্ছে কোন পেশেন্ট, তার কিন্তু খুব স্পেসিফিক সাইড এফেক্ট কি? পেশেন্ট বলবে অরেঞ্জ ডিসকালারেশন অফ ইউরিন, স্যালাইভা or body fluids. Okay, so this is not harmful. Second, the metabolism primarily in enterohepatic circulation. Okay, and rifampicin is enzyme inhibitor or inducer? Enzyme inducer or inhibitor? Inducer. So rifampicin is enzyme inducer. That's why when you give other drugs, other therapies with rifampicin, like anti-diabetic therapies, oral hypoglycemic drug, so the rifampicin can hamper the effect of the drug. That's why you have to alter the drug to insulin, stop OH and start insulin. Okay. Second, there is a chance of oral contraceptive pill failure if you give the OCP along with the rifampicin, right? So you have to use ask the patient to use the barrier method or other contraceptive methods, not the oral pills. So elimination primarily 30% by bile, mostly by bile and stool and feces. So the renal function, the altered renal function does not exhibit any adverse reaction, accumulation of rifampicin, right? So most common drug reaction is orange discoloration of saliva. Second, it is hepatotoxic, but it is less hepatotoxic than isoniazid. The specific hepatotoxicity bola bhul, actually the specific LFT parameter, যদি কোনো পেশেন্টের LFT parameter দেখিস after giving rifampicin, then you can find it as indirect hyperbilirubinemia. There is jaundice, there is hyperbilirubinemia, but the indirect hyperbilirubin is more than that of the direct bilirubin. So this is harmless. So you can continue the therapy. Second, rash and thrombocytopenia. The most important, these are the most specific symptoms. Thrombocytopenia, flu-like syndromes and hemolytic anemia. So hemolytic, and এটাও কিন্তু MCQ. Thrombocytopenia, hemolytic anemia and flu-like syndrome. These are specific of rifampicin. Okay. So patient rifampicin নিচ্ছে কোন patient, তার দেখবি পেশেন্টের একটা পেশেন্ট বলবে তোকে ইনিশিয়ালি বলতে পারে যে আমার খুব ফিভার আসছে, আমার একটা ফ্লু এর মতো রাইনোরিয়া হচ্ছে, একটা কাফ হচ্ছে, তো দিস ইজ ফ্লু লাইক সিনড্রোম টিপিক্যালি কজড বাই রিফাম্পিসিন। সো তখন কি করতে হবে, রিফাম্পিসিনটা ইন্টারমিটেন্টলি দিতে হবে, মানে কম ডোজটা কমিয়ে, হয়তো ইন্টারমিটেন্ট ডোজ দেওয়া যেতে পারে অথবা ডোজ কমিয়ে ডেলি দেওয়া যেতে পারে, ঠিক আছে। সো মেকানিজম অফ অ্যাকশন অফ পাইরাজিনামাইড এক্ষুনি বললাম তো, পাইরাজিনামাইড activates in acidic end. একটা কথা বলা হয়নি, so both these isoniazid and rifampicin, these both drugs kill intracellular and extracellular bacilli, right? Pyrazinamide kills only intracellular bacilli, not the extracellular one, because the acidic environment helps to produce its active metabolite pyrazinic acid, which is harmful for bacteria, right? So the fatty acid synthase 1, FAS1 is inhibited by the pyrazinic acid, and rapidly from GI tract, metabolism mostly by hepatic, and it is one of the most hepatotoxic drug in the regimen. So if the patient develop hepatotoxicity after giving ATD, antitubercular drug, pyrazinamide, you should never give pyrazinamide. You should never re-administer pyrazinamide, okay? Because it is the most hepatotoxic drug. INH and pyrazinamide causes hepatic necrosis. Elimination mostly by renal route, 70% by renal route, by glomerular filtration. But what is the difference between INH and pyrazinamide? So INH also, the metabolites of INH also excretes via urine, and pyrazinamide also, right? But we give INH in case of CKD full dose, but in case of pyrazinamide we cannot give in the full dose. Why? Because these metabolites, that is the pyrazinic acid, is toxic for kidney. That's why although it is excreted by urine, the pyrazinic acid may harm the kidney. That's why in case of chronic kidney disease you have to alter the dose of pyrazinamide, right? And what are the most ADRs? Hepatotoxicity, hyperuricemia. So this is another most typical of pyrazinamide, hyperuricemia and sideroblastic anemia. So hemolytic anemia is caused by rifampicin, sideroblastic anemia is caused by pyrazinamide. So what is the mechanism of hyperuricemia causing by pyrazinamide? Pyrazinamide active metabolite ki pyrazinic acid, right? And so the uric acid and pyrazinic acid both competes with each other in renal excretion, right? So the pyrazinic acid arrests uric acid from excreting through the kidney. So uric acid accumulates in the body, which produces hyperuricemia. So this is not because of increased production, but due to defective elimination of the uric acid. Okay, so this is called hyperuricemia. So if you encounter a patient having hyperuricemia causing due to pyrazinamide, তুই কিন্তু xanthine oxidase inhibitor like febuxostat or allopurinol দিবি না, right? কেন? তারা তো তাদের mechanism of action is to halter the production, but তোকে কি করতে হবে, eliminate করতে হবে through the urine. So you have to give the proben acid, that is hyperuricemic drug, যেটা ইউরিক অ্যাসিডটাকে এক্সক্রিট করবে, রাইট? So ethambutol, mechanism of action of ethambutol, cell wall of bacilli consists of one important lipid molecule, that is arabinogalactan. So ethambutol inhibits arabinogalactan production, right? But it is mostly bacteriostatic, not bactericidal. That's why if you give it with INH, then the action of INH actually increases. Ethambutol এর কিন্তু খুব একটা এই রেজিমেনের খুব একটা ইম্পর্টেন্স নেই rather than other drugs. Other drugs are bactericidal, this is bacteriostatic, but to complete the regimen and to lessen the chance of drug resistant, INH resistant, you have to give the ethambutol, right? So ethambutol actually excretes through kidney, and that's why you have to alter the dose of ethambutol in case of chronic kidney disease, right? So the pyrazinamide and ethambutol, if the glomerular filtration rate is less than 30, then you have to give pyrazinamide and ethambutol alternate day, thrice weekly, and isoniazid and rifampicin daily, same as the other in other patients, right? So the one most important fact is ethambutol is hygroscopic. So যদি কোনো পেশেন্টের আমরা দিই, অনেক সময় কোনো পেশেন্টের কোনো ড্রাগে টক্সিসিটি হলো, হ্যাঁ, টক্সিসিটি হলে আমরা এটিডি স্টপ করি, পুরো এটিডি স্টপ করে আমরা দেখি রিচ্যালেঞ্জ করে কোন ড্রাগে তার টক্সিসিটি অ্যারাইজ করছে, তখন কিন্তু ইথাম্বিউটলকে উইদাউট প্যাকেজ কোনোদিন দিতে নেই, বিকজ ইট ইজ হাইগ্রোস্কোপিক। ওকে, হাইগ্রোস্কোপিক হওয়ার জন্য যদি প্যাকেট খোলে তো জাস্ট নষ্ট হয়ে যাবে ওটা, হ্যাঁ। আমি ক্লাসে আছি। আচ্ছা, so the most important side effect is loss of visual acuity, optic neuritis, color blindness, and scotoma. So if you have to prescribe the ethambutol, that is the 6 regimen, the drug sensitive regimen, you have to ask the patient to go to ophthalmologist and for checkup monthly at least, because this ethambutol induced optic neuritis, though it is reversible, but it is dangerous. Okay, and the most another most important toxicity of ethambutol is production of rash. Okay, so আমরা কি বলি HRJD, right? যারা র্যাশ করে তারা কিন্তু অপোজিট সাইড থেকে বেশি করে, ইথাম্বিউটল বেশি, দেন পাইরাজিনামাইড, দেন রিফাম্পিসিন, দেন আইসোনিয়াজিড, ঠিক আছে? So how do you follow up the patient? By in case of microbiologically diagnosed pulmonary tuberculosis, you have to follow up with sputum smear examination. You have to do sputum smear examination at the end of IP and CP, that is at the end of 2 months and 6 months. And the new guideline says that the follow-up of the therapy must be prolonged, like sputum smear examination after completion of therapy, after 6 months, 12 months, 18 months, and 24 months, to see if there is any recurrence or not, right? And daily weight measurement. So in case of extrapulmonary tuberculosis, suppose a patient is diagnosed with lymph node tuberculosis, so তাকে তো sputum examination করে কিছু হবে না, তাকে কি করতে হবে? You have to assess the lymph node size periodically, right? And in case of pleural effusion, you have to do chest x-rays serially, right? So in certain cases একটা পেশেন্ট তোর কাছে আসতে পারে, সাপোজ লিম্ফ নোড টিউবারকুলোসিস ছিল or pleural effusion ছিল, তুই ডায়াগনোজ করেছিস, you have given the ATD, first line ATD. After that, after 2 weeks or after 4 weeks, patient তোর কাছে ফিরে এলো stating that lymph node size বেড়ে গেছে or effusion has increased in size. তুই কি ভাবলি যে সাপোজ this is a case of treatment failure, but this is not. Why? There is a term called paradoxical reaction. What is that? After giving of ATD, the dead bacilli, tubercle bacilli are dead, most of the tubercle bacilli, and the dead bacilli exerts more immunological reaction. Okay, especially in case of extrapulmonary tuberculosis. So this immunological reaction leads to flare of those primary extrapulmonary sites. এই যে ইমিউনোলজিক্যাল রিঅ্যাকশনটা হচ্ছে তার জন্য আইদার লিম্ফ নোড বাড়তে পারে, আইদার ইফিউশন বাড়তে পারে, বা এরকম হতে পারে কোন লিম্ফ নোড টিউবারকুলোসিস পেশেন্টের ইফিউশন হতে পারে, কোন ইফিউশন পেশেন্টের লিম্ফ নোড আসতে পারে। দিস ইজ কল্ড প্যারাডক্সিক্যাল রিঅ্যাকশন। Okay, so you have to wait for 3 months or 12 weeks. If this problem persists after 12 weeks, then তোকে তখন কি ভাবতে হবে? You may be dealing with drug resistant tuberculosis or other diagnosis. So you have to wait for 3 months at least. And serum creatinine monthly for first 3 months of treatment, and then quarterly till the patient. So this is for drug resistant TB. If the patient is receiving aminoglycoside, then you have to check the creatinine periodically. So this is a brief chart of most, actually the adverse drug reaction, অনেক adverse drug reaction আছে যেগুলো আমাদের গাইডলাইনে আছে, বাট তোদের ইম্পর্টেন্ট হচ্ছে দুটো, যেটা হচ্ছে আমরা খুব এনকাউন্টার করি কি হেপাটোটক্সিসিটি। একটা পেশেন্ট হলো এটিডি ইনডিউসড লিভার ডিজিজ হয়ে গেল, এরপর এটিডি ইনডিউসড হেপাটোটক্সিসিটি হলো। সো হাউ ক্যান ইউ ম্যানেজ দ্য এটিডি ইনডিউসড হেপাটোটক্সিসিটি? দিস ইজ ভেরি ইম্পর্টেন্ট। সো হোয়াট ইজ এটিডি ইনডিউসড হেপাটোটক্সিসিটি? If after giving ATD you have to follow up with LFT, subsequent LFT report. So if the LFT report suggestive of the GPT GOT level is more than 5 into upper limit of normal, that is if the patient is, the normal is 40 and 42 GPT and GOT, if the level of GPT and GOT after starting of ATD is 200 and 300, somewhat like that, that means ki more than 5 times increase hoyeche, or more than 3 times increment with symptoms. Suppose pain, abdomen, vomiting, jaundice with 3 times of upper limit of normal increase of GPT GOT. So this is called ATD induced hepatotoxicity. Then you must have to stop the ATD, anti-tubercular drug. Okay, so after stopping of ATD you have to follow up the patient with repeat LFT after 2 weeks. So in between that, to the এই যে ধর একটা স্পুটাম পজিটিভ টিউবারকুলোসিস পেশেন্ট, তাকে তো তুই এটিডি মানে উইদাউট এটিডি রাখতে পারবি না, বিকজ তার থেকে আরো স্প্রেড করার চান্স থাকবে। সো ইউ হ্যাভ টু স্টার্ট দ্য হেপাটোপ্রোটেক্টিভ রেজিমেন। হোয়াট ইজ দ্যাট? লিভোফ্লক্সিসিন অ্যান্ড ইথাম্বিউটল। এগুলো কিন্তু খুব ইম্পর্টেন্ট তোদের, মানে প্র্যাকটিক্যাল প্লাস এমসিকিউ। হোয়াট ইজ হেপাটোপ্রোটেক্টিভ রেজিমেন? লিভো অ্যান্ড ইথাম্বিউটল, এলি রেজিমেন। ইউ হ্যাভ টু স্টার্ট উইথ দ্যাট। So after 2 weeks follow up, if the LFT comes back to normal, that is less than 2 into upper limit of normal, then you may have to reintroduce one by one drug. That is, you have to reintroduce Isoniazid first, follow up after 2 weeks LFT, it is normal, then Rifampicin. Okay, so LE followed by H followed by R. After that, after reintroduction, after the completion of, so I would never use what drug? Pyrazinamide. Okay, so after successful reintroduction of both the H and R drugs, so the regimen will be H, R, LE. L was there and E was there. So I would omit the L part and the complete regimen would be H, R, E for 9 months. This is the regimen. And in case of rash caused by ATD, so কি করতে হবে তাকে? Patient, you have to stop the ATD, you have to treat the rash first, then after disappearance of the rash you have to reintroduce the drug one by one. So কে বেশি করে? ইথাম্বিউটল বেশি করে। তাকে কোন ড্রাগ আগে স্টার্ট করতে হবে? আইসোনিয়াজিড আগে স্টার্ট, বিকজ যার চান্স কম। সো স্টেপ বাই স্টেপ, ফার্স্টে আইসোনিয়াজিড 3টে ডোজে দিতে হয়, 100, 200, 300 এরকম করে দিতে হবে। তারপর রিফাম্পিসিন, তারপর পাইরাজিনামাইড, তারপর ইথাম্বিউটল। ঠিক আছে? So what are the treatment outcomes? What is called cured? The most important is cured and treatment completed. So what is the difference? শুনতে তো একই লাগছে, কিওর মানে তো ট্রিটমেন্ট কমপ্লিট, বাট that are not same, because cured means after completion of the therapy the sputum smear is negative, but treatment completed means treatment is completed but sputum smear patient sputum smear follow up করাইনি বা sputum smear করা হয়নি due to any another reasons. So this is treatment completed, but you cannot declare the patient as cured, right? Next is failure. So the sputum smear or culture is still positive after the end of the therapy, and lost to follow up, not evaluated, treatment regimen changed. Suppose patient after 2 months of therapy, after the completion of IP, you have to do a sputum smear examination. Suppose still this is positive, right? So we have to do CBNET again. So if there is rifampicin resistance, then the treatment regimen has to be changed from DS to DR-TB. Next, TB and other comorbidities. So most important two comorbidities are diabetes mellitus and HIV. So diabetes mellitus and HIV both are uncontrolled. Diabetes mellitus is a state of immunocompromisation, right? So in case of diabetes, uncontrolled diabetes mellitus, the chance of tuberculosis is more high, and vice versa. In case of tuberculosis, এই কথা বলিস না, এই কারা কথা বলছিস রে, কথা বললে হয় তোরা এখানে এসে পড়া, নয়তো আমি বেরোচ্ছি, এরকম করলে কিছু আমিও বুঝতে পারছি, আমার কনসেন্ট্রেশন কিন্তু হচ্ছে। ভালো না লাগলে তোর যদি কোনো কোয়ারি থেকে আমাকে এখনো জিজ্ঞেস কর, কিন্তু কথা বললে কিছু আমি বুঝতে পারছি না, ঠিক আছে? সো in patients suffering from tuberculosis and diabetes, tuberculosis is a chronic infective state, so which may result in increased cortisol level and may result in uncontrolled diabetes mellitus. That's why in patients and also in patients having diabetes with TB, there is chance of treatment failure and emergence of drug resistance because of immunocompromised state. So if you treat diabetes in case of TB, you have to stop all oral hypoglycemic drugs because of the which drug? Because of rifampicin, because rifampicin is enzyme inducer. So there is every chance of treatment failure. So you have to switch from oral to insulin, right? And TB with HIV. দেখি তোদের আগে পড়েছি TB HIV. So TB HIV হলে মানে বেসিক্যালি কিভাবে আমরা ডিটারমিন করব TB HIV পেশেন্টস এর? According to the CD4 criteria. So if the CD4 is less than 200 and more than 200, so less than 200 এর TB এর কি রকম হতে পারে? Less than 200 CD4 count, that means severely immunocompromised individual. তাদের tuberculosis কি রকম হবে? Mostly they are disseminated one, miliary tuberculosis, disseminated tuberculosis and drug resistant tuberculosis. And if CD4 is more than 200, then mostly তারা secondary tuberculosis যেরকম আমরা দেখি সেরকম হতে পারে। So the most important part is if a patient newly diagnosed with tuberculosis and HIV simultaneously, because in each TB patients you have to do HIV test before initiation of therapy. So suppose the patient found to be HIV positive, then you have to start the ART also, antiretroviral therapy. But whether you should start both of this ATD and ART simultaneously, or what should you do? Any idea? Why? ঠিকই বলেছিস, ATD should be started first, after that ART. Why? Because if you have started ART first, then so ART first হলে কি হবে? Immune augmentation হবে, right? So the CD4 will be active, তাই তো? CD4 will be active because of suppression of HIV. So if the CD4 is active and the TB is not treated, তাহলে কি হবে? CD4 is more active against the tuberculosis and which causes more adverse reactions, তাই তো? This is immunological phenomena. This is called IRIS, immune reconstruction inflammatory syndrome, IRIS, right? So you have to start ATD first, kill the bacilli, then after 2 weeks you have to start the ART. So এটা কিন্তু not TB HIV only, but if HIV is diagnosed accordingly with other disease like blood lymphoma or pneumocystis carini pneumonia, যখন তাদেরও ট্রিটমেন্ট শুরু করবি তাহলে কিন্তু তাদের ট্রিটমেন্ট আগে দিতে হবে, তারপর HIV ট্রিটমেন্ট দিতে হবে, ঠিক আছে? So this is called IRIS. So the 3I, তোদের কমিউনিটি মেডিসিনের সাবজেক্ট খুব ইম্পর্টেন্ট, তোদের লং কোশ্চেনও আসে। কমিউনিটি মেডিসিন এখন চলছে, কমিউনিটি মেডিসিন চলছে, কোশ্চেন আসতে পারে, বিকজ the most important 3 I's of PL-HIV TB. What is the first I? There is the ICF, intensified case finding strategy. What is that? In each and every patient of HIV, you have to do intensified TB case finding strategy. You have to do sputum smear examination and X-ray to find the patient if the patient is suffering from underlying tuberculosis. This is called ICF. Second is airborne infection control strategy. Third I, second I, and third I is IPT, that is Isoniazid preventive therapy. So Isoniazid preventive therapy for all patients of HIV. Patient may be on ART or not, regardless of that, you have to give Isoniazid preventive therapy. So what is the new regimen of recommendation of ART according to the NACO guideline? Do you know? Pharmacology to hoyeche to. According to the NACO guideline, so the newest regimen is TLD. TLD means tenofovir, yes, lamivudine and dolutegravir. So if the patient is on TLD then and on ATD simultaneously, because of the rifampicin also, the dolutegravir dose, what should be the dolutegravir dose? So the dolutegravir dose must be increased 50 mg twice daily to decrease the treatment failure, okay? And previously some authors suggested that the rifampicin should be changed with rifabutil, okay, in case of ATD ART simultaneous dosing. Now bedaquiline, শুনেছিস bedaquiline নাম? So what is bedaquiline? It is diaryl quinone group of drugs. The mechanism of action is, this most important is ATP synthase inhibitor. So ATP synthase inhibitor is the most important. So bedaquiline is which group of drug? Which class of drug? Class A drug. All of the MDR-TB regimen must contain bedaquiline because it is one of the most active drugs in treating DR tuberculosis, okay? So the adverse drug reaction which is most commonly encountered is QT prolongation. You have to do periodical ECG and ECG before starting of bedaquiline containing regimen. If the corrected QT interval in ECG is less than 450 millisecond in case of male and less than 480 millisecond in case of female, then you may proceed with bedaquiline containing regimen, right? And during therapy, if the QTC is more than 500 millisecond, then you have to stop the bedaquiline, okay? So this is bedaquiline, and next is delamanid or pretomanid. So what is the mechanism of action of delamanid? Just like isoniazid, that is mycolic acid synthase inhibitor, and another mechanism is there. Delamanid releases toxic nitric oxide which can kill the mycobacteria, right? So these two mechanisms are there. One is nitric oxide and second is mycolic acid synthesis inhibitor. Okay. So delamanid is which class of drug, or pretomanid is which class of drug? Group C drug, right? So this also can cause QT prolongation, just like bedaquiline. So before starting BDQ and delamanid, you have to do ECG and periodical ECG. Okay. So this is the algorithm of drug resistant TB. আমি simplified বলছি, এটা খুব difficult তোদের জন্য। Basically কোনো পেশেন্টের sputum smear is positive, CBNET is also positive for mycobacteria, right? And suppose the rifampicin is resistant, তুই পেয়ে গেলি rifampicin resistant TB, then you have to prove it as MDR. তাহলে কি করতে হবে তোকে? INH resistance দেখাতে হবে, তাই তো? শুধু rifampicin resistance দেখালে তো হবে না, that is mono resistant হয়ে গেল। তাহলে যদি isoniazid resistance দেখাতে হয় তাহলে তোকে কি করতে হবে? আর কি করতে হবে? আফটার CBNET কি কোন এতে তোর কোন ইনভেস্টিগেশনে INH রেজিস্ট্যান্স দেখা যায়? আগের দিন বলেছি ইনভেস্টিগেশন, তাহলে পড়িসনি আগের দিনের কিছু? লাইন প্রোব আসে, ইউ হ্যাভ টু ডু লাইন প্রোব আসে। ওকে, সো লাইন প্রোব আসে করে কি করবি? তুই দেখবি যে অ্যাডিশনাল আইসোনিয়াজিড রেজিস্ট্যান্স আছে কিনা। সাপোজ আছে, INH প্লাস রিফাম্পিসিন রেজিস্ট্যান্স আছে, রাইট? সো দিস ইজ কেস অফ MDR-TB। তখন তোকে কি দেখতে হবে? আর কোনো ড্রাগ রেজিস্ট্যান্স আছে কিনা। তখন তোকে পাঠাতে হবে ব্যাকটেক উইথ DST, ড্রাগ সেন্সিটিভিটি টেস্টিং এ পাঠাতে হবে। তোকে একটা প্যানেল অফ এই যে ড্রাগস গুলো আমি বললাম তার একটা প্যানেল হয়, 16 ড্রাগস এর প্যানেল হয়। এই প্যানেলে তোকে বলে দেবে যে কোন কোন ড্রাগ আর মানে আদার দেন দ্য H and R or the other drugs the bacilli are resistant to, right? So suppose কোনো ড্রাগের রেজিস্ট্যান্ট নেই, suppose the tuberculosis is just resistant to isoniazid and rifampicin, then this is a case of purely MDR-TB, right? So in case of MDR tuberculosis, the new regimen is, so first of all after diagnosing MDR certain criteria কিন্তু তোকে দেখতে হবে কি? First of all, the age of the patient must be more than 14 years, the patient is not pregnant, that is non-pregnant female, right? And the QT prolongation is less than, আমি যেটা বললাম, less than 450 millisecond, আর other contraindication like hepatotoxicity নেই, chronic liver disease নেই। যদি এইগুলো ক্রাইটেরিয়া ম্যাচ করে তখন তাকে bedaquiline containing shorter regimen দিতে হয়, that is B-PAL-M regimen, B-PAL-M regimen. What is B? Bedaquiline, pretomanid, linezolid and moxifloxacin for 6 months. This is the new regimen, B-PAL-M regimen. যদি B-PAL-M regimen ফিট না হয় ক্রাইটেরিয়াতে, সাপোজ অন্য কিছু ক্রাইটেরিয়া আছে, তখন তাকে দিতে হয় all oral shorter regimen that consists of 9 to 11 months. এই যে 5 drug regimen এখানে দেখ দেওয়া আছে, এখানে এই যে this one, linezolid, levofloxacin, clofazimine, pyrazinamide, ethambutol and isoniazid. দেখ আমি কিন্তু একটা কথা বললাম, isoniazid, the patient is MDR, that means the patient is resistant to isoniazid, but I am giving the isoniazid in therapy. কেন এটা? বিকজ আমি কিন্তু দিয়েছি, দেখ এখানে একটা লেখা আছে H, এখানে তোরা বুঝতে পারছিস না, H এর উপরে সুপারস্ক্রিপশন করে একটা H লেখা আছে, দ্যাট মিনস হাই ডোজ অফ INH, not the normal dose, high dose of INH, because you have to complete the therapy, মানে তোকে তো একটা রেজিমেন তৈরি করতে হবে, তো you have to give the high dose INH and followed by the bedaquiline, levofloxacin, clofazimine. So actually bedaquiline এর যদি কোনো bedaquiline containing regimen থাকে, তো bedaquiline must be continued for at least 6 months because the terminal T-half of the bedaquiline is 5.5 months. ঠিক আছে, যদি তার আগে প্রিম্যাচিউরলি স্টপ করিস তাহলে there is chance of bedaquiline resistance also. bedaquiline এর পর আমাদের হাতে কিন্তু আর কোনো ড্রাগ নেই টিবির, রাইট? So this is the regimen and suppose কোনোটাতেই কিছু হচ্ছে না, there is extensive tuberculosis, extensive মানে this is for limited tuberculosis, limited drug resistant tuberculosis. Suppose the tuberculosis is confined to any one organ and this is drug resistant, then you can continue with this shorter regimen or Bedaquiline containing 6 months regimen. But if there is extensive disease or XDR tuberculosis, then you should go with 18 to 20 months all oral longer regimen. Previously it was shorter regimen, the আমি যেটা মেনশন করলাম, but this is all oral longer regimen. তো দেখ আমি কি বলেছিলাম, দেখ বেসিক্যালি এখানে কি আছে, এই যে বিপ্যালএম, হ্যাঁ বিপ্যালএম এলিজিবিলিটি হয়েছে। তো এই যে লঙ্গার রেজিমেনে কি কি আছে, বেডা, তো আমি কি তোরাই বল কি কি থাকবে। অল ওরাল লঙ্গার রেজিমেন করতে গেলে কি করতে হবে, গ্রুপ এ থেকে 3টে ড্রাগ নিতে হবে। কি কি ড্রাগ আছে, বেডাকুইলিন, লিনেজোলিন অ্যান্ড লিভারফ্লক্সাসিন। তারপরে কি নিতে হবে, গ্রুপ বি থেকে যে কোনো একটা ড্রাগ নিতে হবে, কি আছে, বা দুটো ড্রাগ নেওয়া যেতে পারে, ক্লোফাজামিন অ্যান্ড সাইক্লোসিরিন, হয়ে গেল ব্যাস। এটা হচ্ছে অল ওরাল লঙ্গার রেজিমেন ফর 18 to 20 মান্থস। বাট খুব মোস্ট কমনলি আমরা যেটা এনকাউন্টার করি, সাইক্লোসিরিন ইজ অ্যানাদার নিউরোটক্সিক ড্রাগ, মোর টক্সিক দ্যান আইনিজ। ঠিক আছে, আইনিজের নিউরোটক্সিসিটি ম্যানেজ করা যায়, সাইক্লোসিরিন ইজ ডেঞ্জারাস। সাইক্লোসিরিনের যদি নিউরোটক্সিসিটি হয়, মোস্টলি এপিলেপসি হয়, মোস্টলি কনভালশন হয়, কোমাটোজ হয়ে যায় পেশেন্ট। তো দ্যাট লিডস টু প্রিম্যাচিওর টার্মিনেশন অফ সাইক্লোসিরিন। যদি সেই রকম হয় তাহলে কিন্তু আমাকে তোর গ্রুপ সি থেকে একটা ড্রাগ নিয়ে রেজিমেন্টটা কমপ্লিট করতে হবে। ঠিক আছে, দিস ইজ দ্য থেরাপি অফ MDR-TB. Last slide is tuberculosis preventive therapy or TPT. So what is that? What is TPT? Any idea what is TPT? That means ki, so what is the so TPT involves the use of ATD in individual who are infected with MTB but do not have any active TB disease. Mane to prevent this progression from inherent to active disease, you have to give the TPT. But কাদের TPT দিতে হবে, যাদের অ্যাক্টিভেশনের চান্স বেশি থাকবে। কাদের সেটা হবে, ইমিউনোকম্প্রোমাইজড ইন্ডিভিজুয়াল, HIV পেশেন্টস, TB পেশেন্টস, মানে চিলড্রেন লেস দ্যান 5 years উইথ যাদের অ্যাক্টিভ টিবির কোনো কন্ট্যাক্ট হিস্ট্রি আছে, ফ্যামিলি হিস্ট্রি অফ অ্যাক্টিভ টিউবারকুলোসিস, ফ্যামিলিতে কোনো পেশেন্টের অ্যাক্টিভ টিবি আছে, পেশেন্টের এজ হচ্ছে লেস দ্যান 5 years, দেন টু প্রিভেন্ট ফ্রম ডেভেলপিং টিউবারকুলোসিস কি করতে হবে, তোকে টিপিটি দিতে হবে, রাইট। অ্যান্ড খুব ইম্পর্টেন্ট একটা ওয়ার্কার আছে যাদের বলে সিলিকোসিস ওয়ার্ক, সিলিকোসিস যাদের সিলিকোসিস হওয়ার চান্স থাকে। তো সিলিকোসিস যাদের চান্স থাকে, মানে যারা কাদের সিলিকোসিস হয়, সিলিকা প্রোডাকশন কোথায় হয়, সিলিকোসিস কোথায় হয়, বাংলাতে বলে পাথর খাদান। দেখেছিস পাথর খাদান মানে জানিস, বেসিক্যালি ওই যে ব্রেক করে রক ব্রেকিং এর যে কাজগুলো হয় সেখান থেকে সিলিকা প্রোডাকশন হয়, সেগুলো ইনহেল করলে কিন্তু সিলিকোসিস হয়। তো সিলিকোসিস যদি হয়, সিলিকোসিস কিন্তু টিউবারকুলোসিসের বন্ধু, সিলিকোসিস একা হয় না, সেগুলো ম্যাক্সিমাম কেসে সিলিকোসিস উইথ টিউবারকুলোসিস, দ্যাট ইজ এই টার্মিনোলজিটাকে বলে সিলিকো টিউবারকুলোসিস। তো পেশেন্ট সাফারিং ফ্রম সিলিকোসিস মাস্ট হ্যাভ কমপ্লিটেড দ্য টিপিটি, INH-TB, right? So what should be the prerequisite of tuberculosis, TPT? Prerequisite কি prerequisite থাকতে হবে, ফার্স্ট তার অ্যাক্টিভ টিবি হওয়া চলবে না, the active tuberculosis must be excluded by seeing the sputum smear report, তাই তো। So second thing is that monitor hepatotoxicity and so rule out active TB before starting TPT. And so what are the regimens of TPT? পড়েছিস ফার্মাকোলজিতে tuberculosis preventive therapy? There are 4 regimens. Mostly used regimens are 6H, that is 6 months isoniazid therapy. So isoniazid দিলে কি দিতে হবে আমাকে, pyridoxine দিতে হবে, 6 months isoniazid plus pyridoxine preventive therapy 10 mg করে দিতে হয়। Second is 3HP 3 months of isoniazid plus rifampicin, okay, but rifampicin এর টক্সিসিটি কিন্তু বেশি, দ্যাটস ওয়াই এই রেজিমেন্টটাতে যখন 3HP রেজিমেন্টে থাকে অনেক পেশেন্ট টক্সিসিটি দেখা যায়, এখানে কিন্তু প্রেফারেবল হচ্ছে 6H রেজিমেন্ট, ঠিক আছে। অ্যান্ড the 3 HR, 3 months H plus rifampicin regimen, 3 months H plus rifampicin regimen, and 4 months rifampicin monotherapy. Mostly used is 6H regimen and 3HP regimen. So CBNET cannot be used as a follow-up tool, right? Because in case of follow-up, if you do CBNET, then the dead bacilli genetic material also pick up by CBNET, right? But if there is a chance of treatment failure after 2 months, the sputum smear is still positive, then you have to do CBNET again and backtake DST, drug sensitivity testing. Okay, so in that CBNET, if you found that the rifampicin resistance is there, then you have to change the regimen to MDR or drug resistant TB. Okay, then you would continue with the therapy. Okay, and you have to do, no, if there is no resistance but the sputum smear is still positive, then you have to do a DST, drug sensitivity testing. You have to see whether the specimen is resistant to other drugs. It might be possible that the sputum smear is resistant to Isoniazid and Pyrazinamide and Ethambutol also. Then you have to do a DST, drug sensitivity testing.